Hello, hello. Okay. Today is our third lecture on eyelids. In the first lecture, we discussed basic anatomy of the eyelids, inflammatory conditions like the ptosis, infections like style, chronic inflammations like lesion. In the second lecture, we discussed about the eyelid margin diseases, that is trichiasis, atrophion and ectropion. So, if there is any question for starting the third lecture, if you have any questions, please raise your hand so that I can respond. Or you can ask at the end of the lecture. So, should we start? So, by the end of this particular lecture, the student should be able to understand definition and classification of ptosis. Ptosis is called the drooping of the upper eyelid. जैसे उर्दू में कहते हैं कि मरीज हमारे सेटअप में आके कहता है कि आंख का ऊपर छप्पर जो उनका वो गिर गया, ठीक है? तो you should know its definition. Clinical examination of a case of ptosis. I will tell you theory of the examination today, and when you people will be coming on clinical rotations, we will perform it. Management options of ptosis, and the first three points which are written in this learning objective, we will be discussing this part today, and on the coming Friday, inshallah, we will be discussing the tumor of the eyelids. So let's start with the ptosis. As you can see this picture, there is a significant difference between the symmetry of the two eyes. And the right eye looks smaller because the upper eyelid is fallen or drooped. Ptosis is defined as drooping of upper eyelid to a level that covers more than 2 mm of the superior cornea. Normally, the upper eyelid covers 2 mm of the normal cornea. The vertical length of the cornea is almost 10.5 mm, and horizontal length of the cornea is almost 11.7 mm. So in vertical median it is more curved and 10.5. So it covers the 2 mm of the normal cornea in normal people. If it is more than 2 mm, then it may be a case of ptosis. Okay? Normal elevation is largely a function of levator palpebrae superioris, frontalis muscle which is in the forehead, and molar muscles which are in the eye. Now, in the last lecture, while discussing the ectropion and entropion, we discussed that only there are two muscles in the eye where we all get confused. One is quadrangularis oculi. Remember that quadrangularis oculi is supplied by facial nerve, seventh nerve, and this levator palpebrae superioris is supplied by third nerve or oculomotor nerve, and oculomotor nerve supplies most of the extraocular muscles and intraocular muscles also. Okay, except the lateral rectus and the superior oblique, which is supplied by the fourth nerve. So it is supplied by the third nerve. Classification: congenital and acquired. It can be simple, or dysbiogenic. Acquired has causes aponeurotic or senile. Neurogenic, like damage to any nerve. Myogenic and mechanical. Aponeurotic ptosis. Now, if you recall the first lecture, I told you that eyelid has got how many layers? 5 layers. And the third layer is the muscular layer. 90% of the fibers, they insert on the upper and anterior part of the tarsal plate. And 10% of the fibers of the levator aponeurosis are directly inserted into the eyelid skin, the first part, the first layer, and that makes the upper eyelid crease. When we see downward, we can see a linear line which we call upper eyelid skin, which people can see on each other. So now you can see that in this picture, this eyelid crease has gone upward, and this eyelid crease is, this is the crease at the right place, and this eye is ptotic eye. How much is the ptosis we will be discussing in the coming slides. So the cause of ptosis is that the fibers of the levator muscles which are inserting here and making the upper eyelid crease, they are disinserted because of aging, and they, by disinserting and this sense, they are gone up, pulling with it the skin and leaving the marginal skin at its place. That is why there is no power for lifting the levator muscle to pull it or keep it at the right place. Right? Therefore, as you see that in older people we see sunken eyes, and there is mild ptosis of the people usually in the very old age. It is because of this factor. That is the thing to remember is that the loss of those 10% of the fibers, damage to those 10% of the fibers of levator aponeurosis which are inserted in the skin. Got it? Second cause of involution of post-operative. This was the same as I just told you. Now coming to the second cause, neurogenic ptosis. The ptosis is a very simple topic as far as the theory is concerned, and even the critical examination, but you people need to give a little bit of your insight, your time and mindfulness to keep these things remembered. Now, if the third nerve palsy occurs because of many reasons, there are two main reasons of cranial nerve palsies. Before the age of 50, it is usually because of some dangerous thing like some space occupying lesion in the brain. In the people of the age more than 50, it is mostly because of the vascular diseases like diabetes or hypertension. So, whatever is the reason, if the third nerve is damaged and the third nerve elevates the upper eyelid. Consequently, the upper eyelid will become droop, and this will be the condition of the patient. Total ptosis, and patient will not be able to move the upper eyelid because the levator muscle supply is totally gone. बनावी पहली कॉज है एपोन्यूरोटिक और सिनाइल, दूसरी है न्यूरोजेनिक और तीसरी है न्यूरोजेनिक कुछ और कॉज देखें थर्ड है पॉलिसी हॉर्नर सिंड्रोम यू मस्ट बी नोइंग ऑफ द हॉर्नर सिंड्रोम पता है हॉर्नर सिंड्रोम का हाँ हॉर्नर सिंड्रोम इज अ न्यूरोलॉजिकल कंडीशन व्हिच इज कैरेक्टराइज्ड बाय a couple of signs and symptoms. One is small mild ptosis. Second is miotic pupil. Ptosis is pupil is meiose, and the skin of the cheeks become less sensitive and dehydrated. This is Horner syndrome, which is because of the damage in the sympathetic plexus of the spine. Then Marcus Gunn jaw winking syndrome. ये थर्ड में बहुत दोबारा लिखी हुई है. ये Marcus Gunn क्या है? ये it is basically the you can say congenital aberrant or abnormal formation of the third nerve embryologically. Embryologically, there is some fault in the development of the third nerve, or acquiredly it can occur because of some trauma, after which the third nerve, when starts healing, it makes abnormal connections with the facial nerve. So, in Marcus Gunn jaw winking syndrome, what happens when a patient usually it is congenital. Usually it is congenital during the maldevelopment of the nerve. When the patient, it is called jaw winking. When the child drinks the milk or eats something, like look at me, like when he uses his pterygoid muscles like this, or like this. Okay, then his floating eyelid will wink with this movement. With the movement of the jaw, the upper eyelid will wink temporarily, and when the pterygoid muscles are at rest, there will be no ptosis. So that is why it is called Marcus Gunn jaw winking syndrome. Jaw winking, it is related to the movement of pterygoids, which is by or which move the jaw. Now, this is myogenic ptosis, simple myogenic congenital ptosis. It is simply because of the developmental anomaly of the muscle. Like in the previous case, we saw the abnormality in the development of the third nerve. In this case, there is the abnormality of the muscle. And important thing to remember in myogenic ptosis, in the first cause, do you remember I talked about upper eyelid crease? तो मुझे कोई बताया कि which structure makes the upper eyelid crease? मैं बड़ी डिटेल में भी बताया, पहले लेक्चर में भी बताया. What makes the upper eyelid crease? अभी तो बताया आपको. Yes, levator aponeurosis. उसके जो 10% फाइबर हैं, जब मैं इतनी देर से बोल रहा हूँ, तो आई एम एक्सपेक्टिंग कि आप कुछ और समझ के ये लेक्चर को समझने की कोशिश कर रहे हैं, ड्रॉ कर रहे हैं. तो लेवेटर क्या मैं दोबारा ट्रीट कर रहा हूँ कि लेवेटर का न्यूक्लियोनिक फ्रॉम द ऑर्बिटल मार्जिन and comes down. Here is the orbicular muscle like this, and it inserts on the tarsal plate. 90% of the
नहीं ऊपर वाला
power
5 सेकंड
inserted on the upper part and anterior part of the tarsal plate, and they are responsible for the elevation of the upper eyelid. And the remaining 10% of the fibers, they are inserted on the skin. And these 10% of the fibers are responsible for the formation of the skin. So, in apple process, the upper eyelid crease moves upwards in the previous slide because the fibers become degenerated and they pull the skin upward. In simple myogenic ptosis or congenital ptosis, due to maldevelopment, the levator muscle is not developed properly, so upper eyelid is altogether absent. Absent lid crease is a very important sign in the diagnosis of congenital ptosis. It is the only condition it can be asked in the Baba, and it is the only condition in which the upper eyelid crease, the baby is born with ptosis, and if it is dysmyogenic, or there is mal, or in other words, there is maldevelopment in the muscle, the upper eyelid crease is totally absent, and it is diagnostic of congenital ptosis. अब आपको फर्क पता लग गया, एक वो एक्सट्रीम है जो ओल्ड एज में होती है जिसमें अपर आईलिड ज्यादा हो जाती है, और एक ये एक्सट्रीम है जिसमें चाइल्ड इज बोर्न विद एब्सेंट बिकॉज द मसल इज नॉट स्टैंडिंग प्रॉपर्ली. ठीक है ना? तो इसको इस तरह करके याद रखें तो आप भूलेंगे नहीं. अच्छा, अभी लेट्स आप लोगों ने यू हैव बीन हियर माशाल्लाह आफ्टर 3 years of competing. Anyone tell me any muscular disease in which muscles become weakened in all over the body? Yes, very good, excellent. And the same happens with the ptosis. It is also a neurogenic cause, and the most important is the myasthenia gravis. And we all know its tendencies of acetylcholine receptors and whatever. And myotonic dystrophy is simply the avalon. Myotonic dystrophy is, as the name is suggesting, it is acquired dystrophy of a muscle. Same is true with the ocular myopathy. इसको छोड़ दें. Blepharophimosis syndrome, इसका नाम मुझे याद है. It is a, जब भी syndrome आता है, बस इसका मतलब होता है कि ये इसके साथ और चीजें हैं. It syndrome means something which has a few signs and symptoms coupled together. This is the meaning of a syndrome, and we will not go in detail in blepharophimosis syndrome in detail. Just remember that the important thing is that it is genetic, and it is usually seen in the boys more commonly. And when you see a child with this syndrome, in 90% of the cases you will find a similar findings in his father. The findings are ptosis. The second important point is the atrophy of broad nasal bridge. अभी अभी तीन चीजें याद रखें. ब्लेफारोफिमोसिस सिंड्रोम में ptosis तो होता ही है, साथ में एट्रोफियोन होता है और ब्रॉड नेजल ब्रिज होता है. इसकी डिटेल में मैंने नहीं जा रहा कि पता नहीं आपकी बुक में ये डिटेल में लिखा है कि नहीं, लेकिन ये कॉजेज ऑफ टोसिस में आप माइग्रेन कॉजेज में याद रखें। अभी हमने आपको न्यूरोटिक कॉज डिस्कस की, न्यूरोजेनिक की, माइग्रेनिक की। अब मैकेनिकल कॉज एज द नेम इज सजेस्टिंग समथिंग इज पुशिंग mechanically the upper eyelid. Obviously it will fall down like a big lesion on the upper eyelid. If there is a big lesion on the upper eyelid, what will it cause? It will cause the upper eyelid to drop down because of pressure. There can be other mechanical causes like any tumor, like squamous cell carcinoma of the upper eyelid, Schweitzer gland, which is the most common tumor in the upper eyelid, basal cell carcinoma, or any other mechanical lesion like hemangiomas, cavernous hemangioma, or these sort of things. आपने नाम भी सुने होंगे, लेकिन any lesion which is present on the dermoid cyst आपको पता ना, it can be anywhere. So in the eye, it is usually present on the supratemporal or nasotemporal part. If there is a large dermoid cyst, it will also cause upper eyelid to mechanically come down and cause a ptosis. And the treatment is obviously the removal of the cause. तो ऑब्वियस हैंड पर डोजेस यही है, ये नॉन है, आईलिड ट्यूमर है, आईलिड स्वेलिंग है, कभी-कभी एक्यूट एलर्जी रिएक्शन हो जाता है ड्यू टू सम ड्रग्स, जिसके अंदर जैसे फीवर जॉनसन सिंड्रोम है, उसमें तो रैशेस वगैरह बनते हैं, बट इन सम केसेस there is a swelling of all the body including the eyelid, so it causes very temporary ptosis, and when the allergic reaction is over, the ptosis is not discharged. Now these are now we are going towards the examination of ptosis. I will just go very briefly through the theory of the ptosis of examination, and we will discuss and we will perform, we will demonstrate it in your clinical locations. But the things which theoretically you must know, when a patient comes with ptosis, you have to first of all, with a torch, you will just observe the face of the patient. It is unilateral or bilateral, complete or partial, frontalis overaction, that is if there is the ptosis of the lid, the patient unconsciously uses his frontalis muscle and frowns to see the things. Is there any frowning? Altered head posture. For example, if there is ptosis of congenital ptosis of both the upper eyelids or acquired ptosis, obviously the patient will have to see by moving his chin up like this. Is there up chin posture? These are the obvious signs which direct you towards the diagnosis on general inspection. Then this is the specific tests, and let me first show you. There are 4 basic tests. These are very simple. I just need your attention for the last 5 to 10 minutes. There are 4 basic tests or measurements, you can say, as in surgery and medicine or in any specialty. We start with inspection, then palpation, and so on. And in the end, we call the auscultation. Similarly, on inspection, we saw the face of the patient. Next step is the palpation. Instead of palpation, we use the word measurements in the case of ptosis. first thing आवाज ना आएगा. First thing is that we will with the ruler and the torch. That's why I asked yesterday on Friday, on Thursday perhaps. I asked the people who are coming to the live watch. यार आप लोग वापस आ जाते हैं. It's too late. It's almost ending of the lecture. It's almost, the lecture is almost finished. Please. So, with the torch and transparent ruler, we measure the distance between the upper eyelid margin and the corneal reflex. When we will show the light into the eye, the reflex of the torch will be shown on the cornea. We will measure the distance between the upper eyelid margin and that reflex. It is called marginal reflex distance or MRD. Normally it is 4.5 millimeter. Universally it is accepted by many studies and observations. So if a patient has got ptosis, the upper eyelid will be somewhat here, and maybe when you measure his ptosis, his MRD becomes 2.5 millimeter. MRD will be decreased in ptosis. It's common sense, okay? So you will minus 2.5 from the universal number as 4.5, so it will become 2. So you will label that the patient is having a ptosis of 2 millimeter. So if it is 3 or 3.5 or whatever, if for example if there is 0 MRD, then 4.5 minus 4.5, it is 0. So it becomes, you will say that patient has got severe ptosis. So MRD is very important in diagnosis. Though it is very simple, it is very important from examination point of view also. And MRD की एक ना एक स्लाइड जरूर पढ़ी होती है हॉस्पिटल. उसके बाद ये देखिए इस तरह मेजर करते हैं MRD को. ये जैसे टॉर्च का रिफ्लेक्स पड़ रहा है, इससे आपने कोई भी पॉइंट्स पे ले लिया और इधर से लेकर आईलिड मार्जिन तक ड्रॉप कर दिया. ठीक है? Should I move on? Now the second thing in the measurement is the upper eyelid crease. As we discussed upper eyelid crease. This is the upper eyelid crease formed by the fibers of the levator pubis perioris. And we ask the patient to see down, as you can see in this picture, and you can see this ruler. When he sees down, the lid crease becomes very thin, but still it is visible in normal people. You measure the distance between the upper eyelid crease, which is clearly visible here, from here to the upper eyelid margin. From here to here, but in downward gaze. So, in downward gaze, the upper eyelid crease is measured normally. It is 10 to 12 millimeter, and this is very important measurement. It is for checking the function of the levator muscle, which is supplied by the third nerve, because its functionality is very important and key factor in the management and picking up the right surgical procedure. So it's very simple, just try to concentrate. It is the primary gaze, and we place the ruler at the upper eyelid margin, right? समझ आ रही है? इस दरमियान वाली तस्वीर को देख, हमने रूलर कौन सा है वो ऊपर eyelid margin पर रखा हुआ है और पेशेंट सीधा देख रहा है, और ये देखिए थंब नजर आ रहा है. ये थंब हमने रखा है upper eyelid drooping, and the purpose of placing the thumb is that the patient may not use his pentalis muscle, so that he may not do frowning, and he may not use his pentalis muscle to elevate the upper eyelid, to negate its function. When this is the first step, after that we will ask the patient to see as much as down he can, as you can see in the lower picture, right? After that you will ask the patient to move as up as he can. Then you will measure the lowermost distance to the uppermost distance. How much eyelid has moved from the lowermost position to the uppermost position? It is very simple. Got it? So normally the levator function should be more than 15 millimeter. That is, from the lowermost portion to the uppermost portion, it should move at least more than 15 millimeter. If it is less than 15 millimeter, then there is a classification written in the book that it is poor, it is moderate, or it is less, and more than 50 millimeter is the normal levator function. In young people, usually it is more than 28-25 millimeter. This is Marcus Ganja syndrome, which I just demonstrated in front of you people. This is the picture where the patient is having no ptosis, and when she is using her pterygoid muscles, you can see the eyelid is ptotic, and when she eats something, the eyelid continuously starts moving, like closing, opening, closing, and opening. Got it? So it is usually present in the children. As it is related to the jaw, so it is called jaw wrinkle syndrome. Marcus Gum is the name of the scientist. This is the classification. Mild ptosis is less than 2 millimeter, moderate ptosis is 3 millimeter, severe ptosis is 4 millimeter or more, and levator function, which we just checked, 8 millimeter or more is good, 5 to 7 millimeter is fair, 4 millimeter or less is poor. But normal is, fair is also not normal, but it is fair if it is 8 millimeter but less than 15 millimeter, it means it is still functional, and we can adopt a surgical procedure in which we can manipulate the levator muscle. But still it is less than the normal. Normal is always more than 50 millimeters. These are the surgical treatments of the ptosis, which we will be discussing later, and in the next lecture, inshallah, we will be discussing our last lecture of eyelids, in which we will discuss the benign regions of the benign tumors of the eyelids and malignant tumors of the eyelids. Thank you very much. Any questions? हमारे पास 10 मिनट है.